presenting on craniovertebral instability. I have Ms. Jessica Castro, myself, Tavian Harder. So the objectives are students will understand the principles and concepts about craniovertebral instability. Students will understand the causes of craniovertebral instability. Students will know clinical manifestations and functional limitations regarding craniovertebral instability. Students will learn about tests and measurements to diagnose craniovertebral instability. Students will know about differential diagnosis for craniovertebral instability. Students will be able to understand the elements and phases of the rehabilitation process for this type of injury.
So the craniovertebral region is a collective term that refers to the occipital, atlas axis, and supporting ligaments, which accounts for approximately 25% of the vertebral height of the entire cervical spine. This region demonstrates a high degree of mobility but little stability, with the ligaments affording little protections during high velocity injury. It is also confirmed by the occipital and the atlantic axis joint. They are synovial joints, and the anatomy provides more agility and movement. It houses vital structures just like the spinal cord, vertebral artery, and brainstem. Craniovertebral instability is a medical condition that affects the ligaments and vertebrae in the neck and base of the skull. Clinically, instability appears as a subluxation or spinal deformity accompanied by severe pain or neurologic deficits. Several types are recognized. Some of them are the transitional or rotary instability of C1 or the occipital atlantic instability.
Some of the causes is inflammatory, which affects the ligaments, joints, and soft tissues around the craniovertebral junction. This is where the skull connects to the upper cervical spine. This may lead to instability, pain, compression of the spinal cords, and nerve roots. Neoplastic refers to the presence of tumors and abnormal growth that can impact this junction. The deterioration of the intervertebral disc in the upper cervical spine may lead to a loss of disc height and reduced cushioning. Traumatic disorders such as a fall, car accident, or sports injury. Fractures that can lead to misalignment of C1 and C2, which also may compress the spinal cord or nerve roots. Congenital is where it's present at birth. This may be due to an abnormal formation, such as spinal bifida. Manifestations. We have vertigo, which is due to compression or irritation of vestibular structures or nerves. We have dizziness, which is often associated with the same mechanism causing vertigo. Sleep apnea, which may affect the airway of the structures controlling breathing, leading to obstructive sleep apnea. Motor weakness, spinal cord or upper cervical nerves at the cranial junction that can lead to weakness of the limbs and other controlled by those nerves. Autonomic dysregulation, this instability may impact the autonomic nerve system through pressure or irritation of the nerves, and pain. Localized or referred pain in the neck, head, or upper back. You may have headaches, which is often in the occipital region. Nauseous, which is vestibular disturbance. You have muscle spasm. This can arise from the body's response to instability, leading to compensatory contractions. Muscle imbalance, instability can cause abnormal posture and vision problems.
All right, functional limitations. This condition can have significant impact on an individual's quality of life. Instability may result in limitations on neck movement, digestive problems, visual problems, walking, coordination problems, and balance issues. For testing measures, MRI is the most useful method because it allows the clinician to see the base of the skull and the spinal cord and the brain. Also, a upright MRI allows imaging with weight-bearing positions, providing more accurate representation of the spine condition. Also, the X-rays will show bones or non-neural structures, and the patient will move his head on flexion and extension, and CT scans will show some aspects as MRI, but not with the same resolution. Also, we have active range of motion, passive overpressure and resistance, transverse ligament test, alar ligament test, and lateral shear test.
So differential diagnosis, you have torticollis, which could look like your neck is stuck to the side. You have atlantoaxial rotary fixation. It involves abnormal rotation and fixation of the atlas at C1 and C2. This can lead to restricted movement and potential instability. Auditoid fracture without atlanto dislocation. This fracture involves breaks in the auditoid process. If these fractures occur with associated dislocation of the atlantoaxial joint, they can still contribute to instability. So phase 1, which is roughly about 4 weeks, focuses on low precision to activate deep cervical axioscapular muscles. Main objective is to train the flexors and extensors muscle groups to achieve the correct pattern of movement. And then you have strengthening exercises, postural education.
So for phase 2, for weeks 5 and 6, we need a progression in strengthening exercises, so that way they can, the global muscles can gain strength. Also muscle endurance and joint and soft tissue mobilization and posture and balance exercises. For phase 3, which is weeks 6 to 12, we have to prepare the entire body for return to activity. We have to improve muscular strength and endurance, and also progression in the patient's posture and recommendations or plans for the patient to return to functional and activities.
So the outcomes, with improving the cervical spine mobility, we may start with some neck rotations, just slowly turning the head to the side. We may do some chin tucks towards the chest to strengthen the neck muscles. Then we may do assisted neck tucks, using with the patients. Therapists would use our hands and assist gently tilt the head towards each shoulder while relaxing the neck muscles. Assisted neck rotations with assistant gently using our hands to rotate side to side. Then we may do some gentle stretches. Pain management, we may do some heat and cold therapy, apply heat or cold packs to reduce muscle tension and inflammation. We may also do a gentle massage. Musculoskeletal function, strengthening exercise incorporate upper back muscles such as isometric neck exercises and resistant band exercises. And we may also work on some postural training. So we have the overview. Craniovertebral instability is a subluxation and spinal deformity with pain. We have functional limitations, neck movements, difficulty swallowing, limited walking, visual impairments, and has been said to have a controversial diagnosis. This is just due to figuring out what is a clinical term for craniovertebral instability. It's an extensive rehabilitation process, and the recovery is dependent on the mechanism of injury and patient. Thank you.
Can you go back to your test and measure slide? Okay, so those are excellent test and measures. Very good job. So whenever someone has craniovertebral instability or any type of problem at the craniovertebral junction, these are tests and measures that you want to complete, especially the transverse ligament test, alar ligament stress test, and also lateral shear test. What could be another valuable special test that you most definitely want to add to this list? Yes. So if someone has craniovertebral instability, write this down. The three major special tests that you want to complete are your transverse ligament test, your alar ligament stress test, and most definitely your vertebral artery test. So when that's even when you're assessing the cervical spine, those are 3 tests you want to quickly rule out. So you want to make sure that there are no issues with the transverse ligament, alar ligaments, and you want to make sure the person is not at vertebral artery compromise. okay? Especially before you treat the cervical spine. And if you're gonna be doing any type of mobilizations or manipulations of the cervical spine, which is a synonymous term. So mobilization, manipulation, same thing. Just different grades. We'll go through that later, okay? So great job with those. Go to your causes. All right, here, what causes craniovertebral instability? One of the hallmark things you want to capture in your history is if the person had a traumatic incident, okay? If there's a history of trauma, all right, you want to notate that because that traumatic event could have contributed to some instability. And most of the time in adults, when they come with craniovertebral instability, with most adults, there's going to be some type of traumatic injury that occurred that led up to that. Whether it's a fall, falls are big and resulted in craniovertebral instability. And also motor vehicle accidents. So if they report a history, they're coming with craniovertebral type of clinical manifestations, and they report a history of a fall, okay, or a motor vehicle accident, you most definitely want to do the transverse ligament test, alar ligament stress test, and a vertebral artery test. And a positive transverse ligament test, a positive alar ligament test, or either a positive vertebral artery test. What do we need to be doing? We need to be referring back to the primary care physician for imaging, or either referring to imaging if need be, okay? Because most radiologists are MDs. So if our state permits us to, whatever state we practice in, we refer directly to imaging. Oh, now, of the clinical manifestations. So these are significant clinical manifestations. Right? So you have headache, you have vision problems. So another clinical manifestation that you could see that is likely goes unnoticed, and you have to pay very close attention to the patient's history, is, what do you think another one may be that we can add to this list? Auditory disturbances, hearing problems. So the patient could present with hearing problems, auditory disturbances. All right? In other words, hearing problems. Especially if this person has been, has encountered some type of traumatic, hope I'm spelling this correctly, traumatic incident. All right, so especially if someone has encountered some type of traumatic incident, they could present with auditory disturbances or in other words, hearing problems. Now, what typically happens when we're in some type of traumatic event, the muscles tend to guard. They go into a guarding state, especially the muscles of the neck, sternocleidomastoid, longus colli, scalene muscles, all these muscles to protect our neck, all right, from excessive movement. So when they go into that guarded state, that hyperactive, hypertonic state, then they have to be released or relaxed. But in a sense, when they do that, that could cause problems too. So a major muscle in the neck that can result in vision problems when it's tight. It can result in auditory disturbances. It can result into headaches. Of course, decreased range of motion, and it actually results into muscle imbalances too. So a major muscle is the what that we have to check. Sternocleidomastoid. The the sternocleidomastoid muscle. Do we know how to assess the sternocleidomastoid muscle? For the tightening, the lengthening of it. Okay. All right. So Jackson, come up here. Lie down for me. Head this way. Very quick screen. So when you assess the sternocleidomastoid muscle, you want to bias the person into some flexion, okay? Because it has attachments at the occipital lobe, okay? So if I want to assess the left FCM, what am I going to do? I'm going to side bend him to the left. Yep. I'm going to side bend him to the left. I'm going to maintain some flexion. I'm going to side bend him to the left and rotate which way? To the left. So I'm side bending to the right and rotate to the left. And so I'm maintaining hips to flexion. Are you wincing a little bit?
Yeah.
His SCM could be tight, but I gotta assess both sides. So now we gotta know the function of the SCM. So why am I side bending to the left? Why am I side bending to the right and rotating to the left to stretch the left SCM? I'm actually assessing the extensibility of it. So you gotta think about the function of the SCM, right? So I stretched it, I side bend to the left. So if laterally, what is it gonna do? I side bend to the right. I side bend to the right to stretch the left SCM, and I rotate it to the left. So what am I doing? I'm doing the opposite motions of what the SCM does. I'm gonna let y'all go back and play around with that. All right, so now I wanna assess the right SCM. I'm gonna side bend him to the left. Remember, I biased him in some flexion. I side bend him to the left, all right? Now, to assess the extensibility of the right SCM, what am I gonna do after incorporating the side bend to the left? Rotate to the right. And I'm maintaining some flexion with this. I feel like his right SCM is tighter than his left, although he went with the left. Okay? But that's how you do a quick assessment of the SCM extensibility. And there's some other techniques too that I'll show you later. But that's assessing the extensibility and taking it through its range of motion. So when you assess the SCM, you're gonna side bend away, right? Rotate toward for assessment. So, very good. Of these clinical manifestations, if someone has a positive vertebral artery test, what of those are they going to present with? They could most definitely have some dizziness. All right. What else? They could have some nausea. What else could they have?
They move their hands in pronation.
With the vertebral artery test?
Yes, sir. But that's what I read.
Okay, so you're saying they move their hands in pronation, like a quick pronation type of movement? Okay. What's another one on here that it's not on here, but it could likely be on here if they have a positive vertebral artery test? It starts with an N. Nystagmus. Okay.